Welcome to Patients at Risk, a discussion of the dangers that patients face when physicians are replaced with non-physician practitioners. I'm Dr. Rebecca Bernard, and today we're going to continue hearing testimony from the Texas Legislature's interim hearing on scope of practice. In the last episode, you heard some of my testimony, and today you're going to hear from a nurse practitioner, Holly Jeffries, who is practicing in rural Texas. And I think her testimony is really important for us to hear because it was particularly impactful and really quite persuasive. So we're going to listen to some of the things that she said. I'll stop during her testimony to discuss some of the points, and then we'll also hear some of the questioning by legislators so that we can understand really what's in their heads and what are the things that they are wondering about that will help us to prepare when we give our own testimony or are talking with legislators. So we'll jump right in to listen to testimony from nurse practitioner Holly Jeffries.
Good morning, members. Thank you for inviting me today. My name is Holly Jeffries, and I'm testifying on behalf of myself as well as Texas nurse practitioners. I've been providing primary care and mental health care in the rural areas for over 22 years. We serve over 30,000 patients because I'm also the clinic owner for 4 rural health clinics throughout the Texas Panhandle. We have no hospitals and no physicians in our counties that we serve, and we provide the only access to primary care and mental health care in our counties. This includes providing care for a large foster care facility, nursing homes. We see the inmates at the local jails. In some districts, we are the school nurses as well as we take care of homebound patients and our veteran population. I also serve on the county's EMS team because in one of our counties, it's only volunteer, and sometimes it's myself and a driver who's a volunteer farmer usually. So we often say rural healthcare is very different in our counties. You never know what's going to walk through your door, whether it's a farmer who having to run in with his equipment, a mother with a new baby, or an elderly person who's alone with little resources. There's a wide array of experience of issues that walk through our door. It also may be a day where the clinic provider is the only person in the county, and so you have to leave the clinic to go serve EMS and take care of an accident that happened in town or across the border. While rural healthcare is unique, the challenges we face when it comes to access to healthcare are not unique. In rural Texas, and to a great extent all across Texas, the shortage of healthcare providers is one of the biggest challenges facing communities. The good news is nurse practitioners have stepped up and taken that role. 2/3 of all healthcare providers added to the workforce between now and 2030 will be nurse practitioners. And according to a recent study looking at a decade of healthcare workforce trends, 76% of nurse practitioners are primary care nurse practitioners, where we have the highest need in the state of Texas. We've also seen an exponential growth in psychiatric mental health nurse practitioners. In the past 10 years, psychiatric mental health nurse practitioners have increased by 134%, while psychiatrist numbers have increased by 15%. Psychiatric nurse practitioners now account for 1 in 3 mental health visits for Medicare patients. I've been a part of that growing trend at West Texas A&M University as well, where we opened a psychiatric mental health nurse practitioner program to meet the needs of our rural region. I'm happy to report that 100% of our graduates to date are either serving in rural areas or at least in underserved areas across the Texas Panhandle.
So I'll just jump in here and say that this testimony is really powerful. She is the only clinician in this area. She has an NP only run practice. She's talking about these rural areas. She's talking about EMS, being there on the scene of vehicle accidents. She's talking about taking care of disenfranchised patients. And then she talks about the fact that she started a program and that her graduates have stayed in rural areas. This is exactly what legislators want to hear. I would imagine that Holly is sort of a unicorn, that there are very few nurse practitioners that are doing what she's doing. But of course, we have to give her credit because it sounds like she is really filling that need that legislators are looking for. Now, of course, her argument that she makes regarding the fact that more NPs are graduating, well, that's just simply a matter of, as we know, those diploma mills and physician graduates just can't keep up, certainly not at the pace that we see with the NP programs. And then her argument that most nurse practitioners are primary care nurse practitioners, that's a little bit of a fallacy. You'll see on a video that I made where I examined data from the American Association of Nurse Practitioners versus data from HRSA, a government agency, that shows that even though they may be trained in primary care, most nurse practitioners are actually not providing primary care. All right, let's go back to Holly Jeffries' testimony.
So that's the good news. The bad news is Texas is still the worst place in the country to work as a nurse practitioner. The Cato Institute ranked Texas dead last in occupational licensing freedom, and we're in the bottom 8 states in terms of regulatory restrictions for nurse practitioners. Texas law requires every advanced practice registered nurse, or APRN, to contract with a physician in order to see patients. How does that protect consumers? That's the common question that we see. It doesn't. The delegation scheme in Texas, also called supervision or delegation, is a misnomer. Texas law requires a monthly meeting or a phone call with a delegating physician. It doesn't require the physician to be on site, to sign off on diagnosis or plans, or even to provide direct care to patients. This is not supervision, it's a regulatory burden. The truth is, patients are protected by checks and balances in the system that already exist and would continue to exist if the state granted full practice to nurse practitioners. Every nurse practitioner has to meet the same standardized education and obtain either a graduate or doctoral degree from a nationally accredited program, pass a national certification exam, and obtain licensure through the Texas Board of Nursing. Then once employed, that nurse practitioner has to continue doing the credentialing process through insurance companies where they validate their qualifications and training to perform certain patient care activities. If there's ever a patient issue or bad outcome, the APRN license is on the line. And since NPs carry their own malpractice, they could risk legal action as well.
Okay, we'll pause here to unpack some of what Holly is saying. So, first of all, she is appealing to the fact that Texas is a pro-business state and also has a little bit of, I think, libertarian tendencies when it comes to avoiding excessive regulation. So she is saying that Texas is one of the states that actually still requires physician supervision and using the argument that that is anti-competitive. Then she talks about how loose supervision requirements are in Texas. And you're going to hear more about this later on some questioning. So to her point about supervision, what's interesting is that in the past, traditionally supervision would have been on site. It would have been one-on-one. That was always the traditional model, or at least very close relationship. Now that's been loosened up significantly. And in part, that has been physicians and medical societies making agreements or deals with legislators and with nurse practitioners to loosen up that supervisory relationship so that they can have a little more freedom, so that they can supposedly go into those rural areas. But now you see that by loosening that up, it's actually being used against physicians to say, well, why do we even need you if you can do this oversight in such a loose manner, or if all you're doing is just checking a small fraction of charts? So to her point, if physicians are not actually truly supervising, then I can see the argument of why are they paying for this supervising fee. On the other hand, she talks about that nurse practitioners are held accountable and responsible for their work. We know that state boards of nursing do not have the same strict oversight as state boards of medicine. And we also know that even though nurse practitioners do have malpractice insurance, that we are not yet seeing them being held to a physician's standard of care in malpractice that is starting to be tested. All right, let's jump back in.
So how would removal of delegation authority in rural areas help address shortages? Well, delegation agreements or requirements run counter to the Texas business-friendly climate. It's really a bad business model for healthcare. I'm really not aware of any other profession where your ability to practice and work is 100% dependent on getting permission from the other profession. When I went to the bank to get a loan for one of my rural health clinics, they said that to me. This is a really bad business model. And it wasn't my part of the model, it was the part of the delegation. And they didn't really want to loan money for that because they said, well, if something happens to your physician, then overnight you shut down your patients without care, and then what? Well, you can't open back up till you find someone else to sign that contract. So I jumped through hoops to do that, and many other nurse practitioners do the same. Since COVID, finding a delegation or delegating physician has also become increasingly difficult, even outside of rural areas. There's an acute shortage of primary care physicians in Texas, and the ones who are available are often aging out, as well as close to retirement. Making matters worse, a growing number of hospitals and corporate health systems prohibit MDs or DOs from delegating to NPs outside of their specific system. Due to these shortages, we've seen a growing number of for-profit physician finder services that match NPs with a delegating physician in their database. Oftentimes someone from out of state for the finder fee and a monthly financial contract.
I just have to jump in here for a quick second because the physician shortage is always the excuse for everything, isn't it? We had to have nurse practitioners because of a physician shortage. Now there's not even enough physicians to supervise the nurse practitioners. So now the physician shortage strikes again. And of course, what would be an answer to this? Solve the physician shortage by creating more physicians and opening up residency spots. But let's get back into what Holly talks about regarding how much money they're paying for supervising physicians.
Delegation agreements are also cost prohibitive and amount to patients paying higher cost than necessary. Delegation contracts are expensive, especially for small rural businesses like myself, where we're already limited by our population in that area, as rural populations are typically not growing. And unfortunately, that cost is often passed on to patients. A national survey of advanced practice registered nurses in 29 states showed that APRNs were paying between $6,000 and $50,000 annually for that delegation agreement. That money pays for the signature, not patient care.
I'm not sure what study is being referenced here, but the literature review that I've done shows that the typical cost of supervision is between $200 to $1,000 per month. So we're looking at $2,400 to $12,000 per year, which is quite a bit less than the amount that she's citing. And then, of course, she says that that is just for a, quote, signature, but we know that supervision is not about a signature. It's about availability, making sure that you're there to answer questions, checking nurse practitioner charts, malpractice, and legal responsibility. But of course, her argument that she's making is very compelling because she is talking about the impact that it has on her small business.
APRN graduates also leave the state for greener pastures. In a survey of Texas APRN educational programs, the lack of full practice authority for APRNs was the number one reason APRN graduates planned on not working in Texas. At a time when state leaders have made it a priority to address the supply shortages and retention of our state's healthcare workforce to meet the demands of Texas, it's a brain drain and it's problematic. Many psychiatric nurse practitioners are also choosing to practice out of state via telemedicine in states that do not require physician contracts. That was recently highlighted in a KFF Health News article where they featured an Austin-based psychiatric nurse practitioner who is providing mental health care to a long-term care facility in Iowa. Why was she doing that? Well, it was because the telehealth company doesn't do business in Texas, citing the overburdensome regulatory structure as their reason. When I opened the first primary care clinic in Carson County, our county ranked 221st out of 254 in the county. It's not a great place to be health-wise. By 2019, Carson County was sitting in the top 10 healthiest counties in the state of Texas. That was not by mistake or coincidence. That was achieved with purposeful planning and implementation of preventive measures, education, and quality care, all provided by nurse practitioners. We were trained to do that, and I was trained to do that as part of my education process as a nurse practitioner.
Wow, that's really impressive. If she was able to turn around healthcare like that in her community, I give her a lot of credit. And I do think, and studies show, that a well-trained nurse practitioner, especially someone with a supervising physician, can provide excellent care to patients. Of course, pointing out that she has been supervised as required by Texas law. And even though she kind of discounts the work of her supervising physician, you do wonder, maybe now it's just a signature for her, but was that supervising physician instrumental in her education and her early development? We really don't know, and it would be very interesting to find that out. I guess I will also say that for every one Holly Jeffries that's performing at this level, we don't know how many non-Holly Jeffries are out there that may have graduated from an online diploma mill and may be potentially harming patients. All right, we'll get back to her testimony.
While you'll hear many stories and anecdotes about nurse practitioner malpractice, they're just that, anecdotes. If you look at decades of data on nurse practitioners, the data overwhelmingly shows they're safe providers. In a 2023 study by Texas A&M, they found that APRNs represented only 2% of all malpractice cases in Texas and nationally over a 30-year period, whereas physicians represented 98% of the claims. A peer-reviewed study published just last year found that full practice laws had zero impact on patient safety as provided by malpractice payouts and adverse action reports against nurse practitioners.
I think we know that malpractice data is definitely skewed in favor of nurse practitioners. For one, the physician is the deeper pocket or the hospital. Typically, a nurse practitioner gets dropped from these cases if they have a supervising physician. What I think is really interesting, though, is if you look at the National Practitioner Database, and I did a video on this that you can find on the YouTube site, you can see that the malpractice rates and the adverse incident reporting has significantly increased for nurse practitioners, while at the same time it's actually decreasing for physicians. So I think that there's a lot more to come on malpractice, and I think as we see more nurse practitioners gaining independence and doing not as much low risk follow-up type things and actually taking over responsibility for patients and dealing with acute issues and managing chronic conditions, I suspect that we're going to see big changes in malpractice numbers in the future.
When it comes to solutions, my recommendation is simple. Remove the delegation barrier in Texas so that we can increase access for Texans. It's not a new solution. It's been tried and tested in 27 other states, as well as the District of Columbia and the military and the VA healthcare system. We're limiting ourselves by requiring unnecessary mandates to increase healthcare costs and limit access to healthcare services for those in need. Removing delegation mandates would allow nurse practitioners to do exactly what we're doing right now, providing access to quality care to patients who need it most, but without the burden, expense, and restrictions standing in our way today. Patients deserve transparency and should only have to pay for the provider that delivers the care, not the one that signs the state-mandated contract. It's a solution for Texas and a solution that communities like myself could definitely use. Thank you.
So, I do have some questions for Dr. Jeffries. Can you walk us through the day-to-day of what you do as someone who focuses on primary care, and how you work independently from physicians when it comes to patient assessment, diagnosis, treatment planning, etc.?
Sure. So just day-to-day in the rural areas, we see patients like we normally would. If we have a question, typically, I've been doing this for 22 years, but I'm dual certified in family practice and psychiatric, so I take care of both of those for our county needs. So typically see the patient, and then as far as if the patient needs additional care, whether that be referral to a specialist, I go directly to the specialist, make those referrals. If I have somebody that's an acute need with cardiac, I text the cardiologist and he picks it up, and we go that route. Mm-hmm. Is that what you're asking?
Yeah. So how often do you, in your experience and in your experience with your colleagues, how often do you all interact or seek supervision from a physician?
So once a month as required. We meet once a month.
So the bare minimum. Okay.
Yes, sir.
Thank you.
So if you have a malpractice suit filed against you, do you have to go to the medical board or do you go to the nursing board?
Well, you could go to either. Honestly, it depends where it's filed.
And let me kind of make sure on this. I think if I file against you, Dr. Jeffries, I think because you're a nurse practitioner,
I would go to the board of nursing.
can I file against you and the physician? So it's like a 2-for-1?
You probably could, but the only time the physician would be involved in that would be if I directly accessed that physician to say and brought him into that case.
Well, we definitely know that that is not true. There are multiple cases in which a physician was held responsible for outcomes even when they had nothing to do with the patient. In some cases, it was because they failed to properly supervise. So I'll link a citation to that.
In every session, we hear, it's okay, we're going to catch up. We're not producing a pipeline. Nobody wants to grow to Groom, Texas. Nobody's graduating medical school and going to Skellytown. So our primary care physicians, as much as we need them and want them and love them, they're not going to where they're needed. Tech graduates, I think 30% of the ones that go into the workforce, and their focus is primary care, but they're still not showing up in these under 1,500 population centers. They're not going to. I get it. Telehealth provides a solution for some of that care. So it's not getting any better. It's actually getting worse. To my NPs, and a point you made, when this first came up, when I was first made aware of it, I guess, it was only going to be for rural Texas. And I wake up and they're in urban. I walk 2 doors down from my practice there in Lubbock as CPA, and I've got a primary care guy that's supervising multiple APRNs, and it's awesome. I walk in the door, and usually within 15 minutes, no matter what ails me, I'm seeing somebody. I'm not seeing the doctor. I have pretty confidence because he's sitting in the door down from them that if I needed to see him or if they needed to have a consult right then, he's there. And I do think I know he reviews the health plans in my history because he can talk to me when I see him in the restaurant. So that's a different scenario. I think the on-site is critical. If you're going to get paid to do a job, you need to be on job to do it because there's nothing that can circumvent the environment in which you're in because you pick up on things in person that you don't have. So to my NPs, to be truthful, I would expand you tomorrow, but not for urban areas. That was never the intent. And it seems like that's where the guys, you know what, I figured out there's buzzwords in sessions. It's either mental health or it's for the kids or it's rural of late. And so anything you can label rural, you immediately get some interaction with your legislature. So if you want to be in rural areas, and to your credit, you've devoted, it sounds like, a huge financial commitment to doing rural health care. I applaud you for that. It sounds like you're successful at it because the outcomes reflect that. We need more of that. And I don't think TMA has the capacity to ensure that's going to happen. In the educational litany of all these things that doctors do versus NPs don't do, is it the residency component? If you had to name one thing that would give you comfort, if NPs met that requirement in their programming, you could tolerate, and to your answer just now, you aren't reviewing all the files. Are you a supervising physician?
Yes.
You do? What's your profession?
I'm an anesthesiologist. We have a physician group, my anesthesia group. There's 26 anesthesiologists and 16 CRNAs.
Okay. And what is your annual fee for that oversight?
Zero.
You get zero.
Zero.
But you're on site. Is that fair to say they're all in geographical location?
Yes, sir.
Where you can see them, touch them, feel them?
100%. Yes, sir.
If they need something right then,
I'm there.
in person.
Yes, sir.
Because telehealth's great. It's going to be awesome. But guess what? Broadband don't always work.
Especially as an anesthesiologist, I have to get in there.
So I'm perplexed, and I'm a little bit always pulled in this, Madam Chair. I kind of had a policy, no scope conversations in my office forever because they're a frustration. But I got to tell you, what we're doing is not working, and it seems to have an answer. I don't think the quality of care issue is, obviously I have a doctor that can be a bad doctor, and I have APRNs that can be bad. If there's something in the educational community that you guys as doctors say, it is critical they do a residency because that's where they're going to get exposed to all these different things that they're going to have in real life circumstances. I think that's where I'm at. Just tell me what they would need to do today that would remove some of this burden. But I will tell my NPs, I'm disappointed that I wake up and you're sitting in urbans. I just don't think that was the intent of the legislature either when we started opening up this door. So something's got to change, but the timely delivery in your 7 things you got to get done as a doctor to be critical patient care, good quality. Timeliness is not there if you don't have a mid-level providing it. And 9 times out of 10, that service is being delivered not at the time of the supervision. Supervision comes at the end of the month. Hey, I got a stack of files I got to go through, and I'm only going to do a random sample of those. So it's a little bit disingenuous to sit up here. We're supervising these people. We're micromanaging their day so that they don't do something stupid, and we have to continue to do that. That doesn't add up. Something's not right. I don't know how to fix it, but it's not right.
That was Dr. Ray Callis's voice that you heard there, and you're going to hear a lot more from him in the next episode. But I just wanted to interject. One of the questions that we heard from legislators a lot was, what would it take for you doctors or TMA or different medical societies to give the thumbs up for nurse practitioners to practice independently? What's it going to take? And often they say a residency or a certain number of hours. But I would say that the answer comes from the Flexner Report, which established in 1910 the standards of independent practice, which was a standardized medical school curriculum, standardized rotations and preceptorships with qualified physicians, examinations, again, standardized. And then, of course, to become a licensed physician, you must complete residency training, which again is standardized. The Flexner Report established that an apprenticeship type model of just working a certain number of hours under someone else was not acceptable, was not adequate for patient safety. So the answer is there is no certain amount of hours or informal residency type program that is going to guarantee patient safety and effectiveness of care.
Let me shift gears to the fees associated. Let's talk contracts.
Yes, sir.
Dr. Hollis had mentioned in her testimony that there are potential financial benefits for doctors to enter into these delegatory agreements with an APR. And these are, I've done some research, and some may be pretty lucrative.
Yes, sir.
And it shows that it's a burden, as she had mentioned, to APRNs, especially in our rural communities. So what I understand, and help walk me through this structure, is that the fees or the delegatory agreements vary, right, for physicians and APRNs. But when they have multiple agreements, some can have flat fees, some can have monthly retainers. But in speaking with some of the stakeholders, some of these retainers are $5,000 to $50,000 annually. And I think Dr. Jeffries had mentioned it, depending on the level of involvement and care. So can you help me understand how these exorbitant, from my perspective, fees that could make it financially impractical?
Yeah, I would love to
provide services in rural communities.
Yes, sir.
Where the population tends to be lower income, on Medicaid, uninsured. How do these contracts support the state's effort to expand access to health care in the highest need areas of our state?
I agree. I've heard a lot of these rumors. I have said even during the last legislative session when I testified, and I'll say it again today, as president of Texas Medical Association, if a nurse practitioner is paying an exorbitant amount of fees, I personally, Ray Callis, will report them to the Texas Medical Board. There is no way, no how. I have been hearing this for 9 years, how people are charging $100,000, $200,000. I've yet to meet the person doing this because we have rules in place that they cannot do that, and we can report them to the Texas Medical Board and they will be handled. Because I'm embarrassed. I am physically embarrassed that a physician would charge that amount of money. The only thing I would charge if I was going to be supervising a bunch of nurse practitioners in rural communities, making sure that I cover my liability, because my liability is going up because I'm having more volume of patients, and make sure that my time is not being pillaged based on that. But there's no way, I can't even believe someone would even charge 50, 60, 300, 400,000. It makes no sense. No sense. I'm here to tell you I'm against that 100%, sir.
And so is TMA against that?
Yes, I promise you.
Okay.
Now you're going to hear some more questioning about supervision fees. And this time you're going to hear some answers from Dr. Sharif Zafran. He is the head of the Texas Board of Medicine, and he makes some clarifications regarding the understanding that legislators have where they seem to think that physicians are being paid just simply to give their authority for nurse practitioners to treat patients without actually playing any role in that care and oversight.
The other thing I'd say that the fees, we keep talking about it. You say there's no formal structure of those. I want to make sure that everybody knows it, but that rural hospital paid those fees because they could only find mid-levels. So it wasn't the mid-level person paying the fees, it was the hospital system. Somebody still paid $250.
But in that hospital, that physician that was supervising all those mid-level providers had to be part of that hospital system. They had to either be the chief of staff or the medical director or the chair of the
I think
prevention
what's
committee might
being
be
lost
part
in
of that
this,
hospital.
I think that's what's being lost in the conversation. There's really no level of supervising going on. That's what the point is being made. And I think when you separate physical on-site physician with those people they're supervising, it's a little bit naive to think that there's real supervision going on, and it just becomes an added overhead burden. If there was a physical physician on site where all of these scenarios you paint have a direct physician that they can have that consult with right while that's happening, that's a different story. That is a business model that guy's time or person's time is occupied doing what they're getting paid to do. So that's what is lost in this. It's the ability, when we claim we're doing all these supervision, it's a review 30 days, one time a month, after the fact of all the chronic or all the clinicals have been done. There's no real value in that.
Senator Perry, but that's not the case in the facility. And let me just make the distinction again, because the way the medical board oversees physicians who are directly supervising versus those who are giving prescriptive authority in a non-facility and are overseeing records once a month is very different. If a physician is directly supervising mid-level providers in the facility, we are going to hold that physician accountable for every encounter that a patient has, whether it be with a mid-level provider or by the physician themselves directly. So that's a different standard that we're applying to that physician. And a physician can say, you know what, I'm going to be a couple hundred miles away and supervise, but I'm telling you, if something bad were to happen, that physician can lose their license. So they are going to hold themselves a little bit more accountable because the amount of oversight that we're going to have in a direct supervision environment, very different in a facility than outside of a facility. There's a lot more culpability and a lot more oversight from the medical board on that physician in that type of setting.
As there should be.
As there should
And
be.
I don't think anybody would argue that if there's a physician oversight supervising people directly, that's a different compensation and a different conversation. But when you have the other, which I think is probably the majority of these supervising contracts, that's not the case.
Dr. Jeffries, we'll go back and forth. You guys in the middle, I'm gonna have something for y'all in just a second, okay? But, so is APRN training, except for CRNAs, which I know they are very stringent, and you have a much smaller ratio. It's very different,
Yes,
and it's on-site
yes.
supervision for CRNAs. So we're going to kind of put those over there. Can you get an online nurse practitioner degree, APRN?
Well, some of the programs are online, and
Are
but
clinicals
nursing
online?
no, just the didactic portion. And honestly, that's nothing new. I mean, nursing has been doing some online classes or courses for 30 years. The clinical portion is all in person, direct patient contact.
So let's throw this out there. If we want to go to more full practice of APRNs, can Texas just say this is the bar? Can we raise that bar and say if we're going to go to full practice, we're going to increase all of this to have this amount of hours and this much clinical and increase?
I think we could have a discussion about that, because I will tell you, the majority of APRN classes now, they are looking to find a supervising physician, and most physicians that they find just sign off on them and they don't give them any clinical expertise. I'm very frustrated that we are not putting the healthcare responsibility that we should be putting patients first. It should not be a diploma mill full, just getting degrees. It's really hard for me as a physician to where we have people that can't even get into medical school because it's so competitive. but you can go get your APRN even if you've never been a nurse yet. It doesn't even make sense. But let's create a bar.
No,
Proof.
I guarantee
you
you.
have to be an RN
That-
to
Okay.
go on.
BSN?
Yes.
In case you missed that little back and forth, Dr. Callis said that you can become a nurse practitioner without having ever been a nurse. And Holly Jeffries said that's absolutely not true. You must have even a bachelor's in nursing. But Dr. Callis is correct in this case because 22% of all family nurse practitioner students attend nurse practitioner school through what's called direct entry, and they can have a bachelor's degree in any subject. And what happens is they get their nursing license kind of simultaneously with their NP degree. So they actually may have never worked a single day as a nurse, and yet they can graduate as a nurse practitioner.
Okay. All right, so we're going to keep having that argument because if we're looking at quality of care and, that's TMA's argument, we're talking about access, we're talking about putting patients first. That's all great.
All right, I think we'll wrap it up there. Still so much interesting testimony to listen to and review. That'll be coming up in the near future. In the meantime, if you'd like to learn more about this topic, I encourage you to get the books Patients at Risk and Imposter Doctors. They're available at Amazon or barnesandnoble.com. We have them on ebook and also in an Audible form. And also, if you're a physician and you'd like to learn more about getting involved in our mission, which is advocating for physician-led care and truth and transparency for all healthcare practitioners, please join our group. It's called Physicians for Patient Protection. You can learn more at our website, physiciansforpatientprotection.org. Thanks so much, and we'll see you on the next podcast.